Take both are not working. Coelom means, what do you mean by coelom? This is a body cavity, right? More precisely, this is a cavity within in between the ectoderm and endoderm of an organism. Either partially or completely either partially or completely lined by mesoderm. Right? Now, as you have come to know during your HS study, that in case of triploblastic animals, there is a body cavity. Either there is a body cavity in between ectoderm and endoderm, alright, or there is no, that is parenchymatous tissue filling the gap between the ectoderm and endoderm. And in some, there is a body cavity. So, when the body cavity is present, it is called coelomata, right? When the body cavity is absent, it is called acinomatic, alright, acinomata. And if there is a pseudocoelom, that is in between the layer, is not, there are other tissues in between two layers. This is called pseudocoelom. Alright. Now, acinomic animals are the platyhelminth piece, right? The tapeworm, the planaria, alright, you know this thing. And pseudocoelomic are the nematode piece, nematodes, etc. Right? So, during the development, what we see that we know the subdivisions of the mesoderm, that is at first the bilaminar germ disc, alright, and from the ectodermal layer there is formation of the proliferation and formation of the primitive stick, and from the primitive stick the mesodermal cells diverges in between the ectoderm and endoderm. This gives rise to the secondary intraembryonic mesoderm. What is this? This is secondary intraembryonic mesoderm. Primary or extraembryonic mesoderm has developed earlier. Alright, this is secondary intraembryonic mesoderm. So now the germ layer is of three, consisting of 3 layers. That is ectoderm, endoderm and mesoderm. And there is a subdivision of this mesoderm as paraxial mesoderm, intermediate cell mesoderm. The paraxial mesoderm is our vertebral column. Alright. And intermediate cell mesoderm gives our urogenital system, especially the development of kidney. Right. And this lateral plate mesoderm is subdivided into 2 layers. Alright. By a elongated cavity, horseshoe-shaped elongated cavity, which is known as the intraembryonic coelom. This is known as extraembryonic coelom. At present, the 2 leaves of the horseshoe are separated. At the top, there is the developing pericardial cavity. In between is the pericardio-pleural tunnel, and then after that is the pleuro-peritoneal tunnel. Right? When after the formation of the floor of the pharynx, that is from the fistula of His, when the laryngotracheal tube will develop and the lung bud will develop. Right? And this lung bud will invade. Alright? This pleural part of the intraembryonic coelom, giving rise the pleural cavity enclosing the lung bud. Right? And in between the pleura to the last part, that is the 2 coelomic cavities in the abdominal part. Right? This will communicate through the pleuro-peritoneal canal, which will be separated by the development of the diaphragm. What my point? Or should I repeat? Should I repeat? Alright. Now, what I told, that as I know, that the development starts with bilaminar germ disc with ectoderm and endoderm. When due to proliferation of the ectoderm, underneath the ectoderm, there is formation of the primitive sting. Alright. From the primitive sting, the mesodermal cells diverge in between these 2 layers. This is called secondary intraembryonic mesoderm. We have subdivision of this mesoderm as the paraxial mesoderm, giving rise to the axis of the vertebral column. The intermediate cell mesoderm that gives rise to the urogenital system, especially the development of kidney, and the lateral plate mesoderm, in which appears a cavity or C-shaped cavity, whose top part is the pericardial cavity, in between is the pericardio-pleural, pleuro-peritoneal canal, right? And the lowest part that fuses with each other after the head fold. After the lateral fold, these 2 coelomic cavities fuses with each other, giving rise to the peritoneal cavity or the abdominal part of the intraembryonic coelom. What my point? Alright. And when this head fold occurs, you see, we have seen that the septum transverse initially at this tear-shaped embryonic disc, alright, it is at the cranial layer, alright, and when the head fold is occurring, what is umbilicus? Umbilicus is the meeting place of the 4 folds of the embryo. This head fold is coming, this is tail fold is coming, and this lateral folds are coming. All these 4 layers, folds are meeting at a place. That is umbilicus. Got my point? That is umbilicus. So when the head fold is happening, then the septum transversal will come down to the inferior and anterior aspect of the pericardial side. Got my point? It was there. And when I go down this will come inferior and anterior aspect of the pericardial, developing pericardial side. With reversal of surface. What is the reversal of surface? This is the parietal surface of septum transversal. This is the visceral surface of septum transversal. Yes or no? Got my point? The back is the parietal surface and the anterior is the visceral surface. Oh, so when it will come down and take a position anterior and inferior to the pericardial sac, there will be reversal of surfaces. That is, somatofluidic layer will become the sphingofluidic layer, and the sphingofluidic layer will be the somatofluidic layer. Got my point? And now you see, when these two lateral folds meets, what the situation becomes. Alright, what is this diagram? This diagram shows the head fold with coming of the septum transversal below the pericardial sac, below and anterior, with reversal of surfaces. And this is the developing guard. This is the developing guard. A part of this main sac will come out. This will come out. This is what? This is the umbilicus. Right? This is the pouch that comes out through the umbilicus. This is called extraembryonic coelom. This is extraembryonic coelom, right? Which is entering into the through the umbilicus into the umbilical cord. What's my point? And this is what? This is the protrusion of the or herniation of the gut, the mid gut, by 5th week, by 5th month, which causes the physiological hernia. So during physiological hernia, we have two things. Number one, herniation of the gut, natural or physiological herniation of the gut, along with the protrusion of the intraembryonic coelom into the umbilical cord, which is known as the extraembryonic coelom. Done? Got my point? All. No, before the fusion of these two lateral compartments of this intraembryonic cilium, what we see that these two layers are enclosing the gut from either side. Alright. The anterior part from the parietal one to the gut. Alright. This is forming the ventral mesogastrium. Alright. And the part from the gut to the dorsal one or the posterior one. This is the dorsal mesogastrium. Got my point? This is ventral mesogastrium and this is the dorsal mesogastrium. Remember, only the stomach has the ventral mesogastrium. No other organ has any ventral mesogastrium. But the dorsal mesogastrium is continued from the stomach, duodenum, jejunum, ileum, the ascending, descending colon, transverse pelvic colon. All these are invested with this dorsal mesogastrium, but in a different nature. But they possess the mesogastrium or the mesoderm. Right? Now, as you can see, these are the intermediate cell mesoderm. How this posterior layer is of this intraembryonic cilium is lining the intermediate cell mesoderm. So, if from the intermediate cell mesoderm, if kidney develops, it will be rectoperitoneal. Yes or no? If from the intermediate cell mesoderm, if kidney develops, it will be behind the peritoneum. What my point? And our blood vessels, that is inferior vena cava, abdominal aorta, all are here. Here is the abdominal aorta, here is the inferior vena cava. So again, this will be rectoperitoneal structure. Again, this will be rectoperitoneal structure here, yes or no? This will also be rectoperitoneal structure. Always remember, all the blood vessels at the origin are rectoperitoneal. When they comes out to supply an organ, they pass through pouches, recesses, fold, ligaments, etc. Momentum, mesentery. Alright. So all the blood vessels at its origin are rectoperitoneal. What my point? Alright. Now let us have a stratification how the organs are coming in relation to একটা ইয়ে হবে কোথায় গেল where is this guy how can you give a biological definition of coelomic cavity or the peritoneal cavity? How can you give the biological definition of the coelomic cavity? What is it? This is a hydrostatic skeleton. This is a membranous hydrostatic skeleton, right? Which has the property of transporting element for nutrition as well as for excretion, right? They support movement and anchors the viscera, right? Other than phagocytosis, wound healing and localization of infection, right? So it is a hydrostatic skeleton, right? What is peritoneum? Peritoneum is a hydrostatic skeleton. Means it has absorptive power, it has secretory power, it can transport things in and out, alright. That is for nutrition or for excretion, right? It gives nutrition to the viscera, supports and anchor, have phagocytotic property and wound healing property and infection localizing property. Alright. So always write this simple term that it is a hydrostatic skeleton. What we call? Alright. Now you see, peritoneum is a blind or closed sac in case of male, right? But it has two small apertures for the coming out of the uterine tube, through which comes out the uterine tube, and there are two apertures in case of female. Got my point? But in case of male, it is a complete enclosed blind sac. Got my point? But in female, as the inferior uterine tube penetrates it, So there are two apertures for the uterine tube. And as it communicates with outside, so the peritonitis, that is spreading of infection over the peritoneum, is more common in case of female than in the male. Got my point? Got my point? So peritonitis is more, as it is an open sac for the female, peritonitis is more common. Take it. Right. Another thing is that there is no content within the peritoneum except a serous fluid for lubrication of the surfaces. Right. The layer which comes to the parietis is called the parietal layer, and the layer which is developed from the somatofluidic mesoderm. Right. And the layer that comes in close relation with the viscera is called the visceral layer. And the mesodermal layer is differentiated into a flattened epithelial cells which are known as mesothelium. The mesodermal cell differentiates into flattened epithelial cells which are called mesothelium, that secretes, absorbs, transport or whatever, right, for the purpose of movement of the contraction, dilatation and movement of the and passage of the blood vessels, so that it can happen without friction. This duplicates these two surfaces and there is a very thin amount of fluid within it. No organ is within peritoneum. Got my point? Number two, if you see, if this is the peritoneal sac, if this is the peritoneal sac, remember all the organs are outside, all the abdominal organs are basically outside this. Right? The organs develop and project into it either from front, from behind or from below. Understood? Either from front, from behind or from below. But none enters into this cavity. None enters into the cavity. Suppose this is the bladder. So one layer will come in front of it partially and reflect back with the parietal one and reflect back to the parietal one. Right? This is the spleen. The spleen is wholly covered. The spleen will be wholly covered by this parietal layer. That is the parietal layer coming into visceral layer and then again reflected back to the posterior abdomen as the parietal layer. Got my point? Similarly, the liver also will be enveloped in this way. And when the uterus ascends from below, definitely bladder and uterus when ascends from below, there will be slits of peritoneum on it, upper part or anterior surface, and there will be diverticula or pouches in between this organ. I am showing you, don't worry, alright, I am showing you. Now, so all the organs are basically extraperitoneal. Alright, they project within the sac. So one layer is attached, intimately attached to its surface, that is called the visceral peritoneum. Alright, and the layer that reflects back to the parietal one is the parietal abdomen. Right? Now let me show you a simple thing. Vertical disposition of peritoneum. How to draw it? In this diagram, as you can see, that the parietal peritoneum, after completely investing on the upper surface of the diaphragm and the anterior and superior surface of the liver, as well as the inferior surface of liver, up to the quadricule, margin of the quadricule, right? Here, these layers are reflected to the stomach, that is major curvature of the stomach, right? Both the layer, right? It is reflected to the major curvature of the stomach. This is the first layer. Right? And after making a newspaper group, this first layer is becoming the fourth layer. Right? And this layer goes up to the anterior border of pancreas. Right? This layer is going up to the anterior border of pancreas. And it is reflected back to a curve, embrace the transverse colon. Right? So this will form the transverse mesoderm. This will form the transverse mesoderm. What do you point? This will form the transverse mesoderm. Alright. Now, the next part reflects back to the jejunum, then over the ileum, giving rise respectively the mesojejunum, mesoileum. Alright, but not the mesoduodenum. Initially there was mesoduodenum also. But in case of tumor, there is rotation of gut. You have read rotation of gut? No. Alright. This is duodenum. Alright. This is duodenum. It was initially completely engulfed by the peritoneum. That is its mesentery. Right? But when it rotates, what happens? Then this layer becomes like this. This is duodenum. Right? And these layers disappear by fusion. So what will be its recent status? This will be like this. These two layers, that is the one layer of its mesentery and the parietal layer gets fused and disappear. This is known as zygosis. Alright. Through the mesentery of the duodenum, that is the mesoduodenum, disappear. Right? So, duodenum is a rectoperitoneal structure. What is the peritoneum? The anterior part will be covered by the peritoneum, not the posterior side. Alright. That's how the duodenum becomes mesoduodenum less. Right? This is called a process of zygosis due to rotation of the duodenum on the right side. What my point? Similarly, if you see the development of the kidney projects from the posterior abdominal wall. Right? Here the parietal layer is over it, only forming. Actually, there is a peritoneum. The organs that comes in relation, that gives the peritoneum to this kidney. Otherwise, it is completely retroperitoneal structure lying on psoas fascia and the fascia over the quadratus lumborum. Psoas fascia and fascia over the quadratus lumborum. Right? As the peritoneum, that is the parietal peritoneum, is attached to what? It's a peritoneal fatty tissue. Yes or no? In relation to the movement and muscle contraction, this attachment of parietal peritoneum with the parietal abdomen, that is through the extraperitoneal tissue, it differs. How it differs? If you see that if it is the bladder, no, empty, very little amount of urine is there. But when it will enlarge and elongate, this is its peritoneum, covering its upper surface and part of its, only upper part of its posterior surface. Alright. But when it will elongate due to distension, this will come in this position. This will be the bladder. Alright. Similarly, the peritoneum will also move up like this. What my point? So definitely this part of the peritoneum in the lower abdomen overlying the bladder is loosely adherent to the parietes. What my point? Otherwise it is not possible, and that's why this is the symphysis period. Right? That's why in a distended bladder, if you put a needle through here, which is known as suprapubic puncture, or you can do a cystostomy also for relief of the patient, because huge dilation, huge distension of the bladder causes tremendous excruciating pain. So if you palpate, yes, the abdomen is full and percus, yes, there is a dullness over the symphysis pubic area, you can be sure that it is distended bladder, and corroborated by the history that the patient has not passed urine for several hours. Alright, you can, closing your eyes, you can puncture this skin, suprapubic skin. Alright, and you will be very happy to see that urine is spotting. Right? What my point? And sometimes during operation or operative preparation or post-operatively, sometimes you need to give a small incision and put this is simple rubber catheter or the needle aspiration, or we can put a Foley's catheter through this suprapubic skin, puncture inside this suprapubic skin. This is very easy. Alright, so you will not be worried when a patient comes to you with retention of urine. Right? You have to palpate this area to see the fullness, then purpose the area, there will be dullness, then puncture it. Alright, done? Alright, so this part of the peritoneum is loosely adherent to the parietes through the extraperitoneal fatty. Right? Similarly, if you see on the posterior aspect, you will find that over the fossa covering the psoas and the quadratus lumborum on the back, alright, there is a huge amount of fat. Kidney is what? Do you know? You have seen the chopping of a lamb or a sheep or a goat. Have you seen? You will see on the posterior abdominal as if there is a tug of fat on the posterior abdominal one, just like this. And on it sits the kidney. On it sits the kidney. What am I calling? So the posterior layer of that is a parietal layer is avidly attached to this thick extraperitoneal fat. And for the kidney, this is called perinephric fat. This is called perinephric fat. What am I calling? And it is avidly attached, so that your training, your muscular exercise, nothing hampers the vision. So there is regional variation in the amount of fat, extraperitoneal fat tissue that anchors the parietal peritoneum to the parietal wall. That is an abdominal parietal. Got my point? All. Now, so uterus projecting from below, kidney projecting from behind, and the guard also projects from behind. As the guard projects from behind, most of the part it will have a two-fold that is like this. That is the dorsal necessity. Not that. Only ventral necessity is attached to the stomach. Right. What are its derivatives? Let's see. What are the derivatives of this ventral mesogastrium and the dorsal mesogastrium? Right. Let me wipe out this diagram. I will talk about hepatorenal pouch of Morison and rectouterine pouch of Douglas. I will talk about all that. These both two pumps are short. Both the hepatorenal pouch of Morison and the pouch of Douglas. Both pumps are short. Alright. Alert me. Oh, it is already 5 minutes yet. Okay. I will give you 15 minutes. To relax your mind, and I will come back after 15 minutes. Right? Let me just draw one diagram and I will leave. And I will leave. You know that if you see from inside the abdomen toward the umbilicus, no sound? Hello, hello, no sound? Not working. Hello? No? No? Sound আসছে না? No sound. Oh, all right. Okay. Now, as you can see, from the diaphragm, from the undersurface of the diaphragm, the peritoneum is falling on the superior and anterior surface of the liver, right? From undersurface of the diaphragm, the peritoneum is falling on the superior and anterior surface of the liver, right? And it is extending, up to the umbilicus. This false-shaped peritoneal fold is known as the falciform ligament. All right, you can see. You can see from inside the abdomen around the umbilicus there are 4 ligamentous tucks. 4 ligamentous tucks. All right, this is like this. If this is the umbilicus, all right, this is called median umbilical ligament. This is obliterated umbilical artery. Left and right, this is umbilical vein. Left. This is urethus. I will tell you, don't worry. Just remember these three terms. Within the umbilicus, we have, at the beginning, there were two veins, two arteries. Right? But within the umbilicus, the two veins fuses to become one. The right disappears early. Left umbilical vein remains as ligamentum teres hepatis. Right? So this one ligamentum teres hepatis. And this obliterated umbilical artery, right and left. Right? This forms the medial umbilical ligament. And the median umbilical ligament is the urachus. It is the urachus, which has come from allantois. Just remember this term, I will explain you at right time. Remember, this is the urachus that has come from the apex of the bladder to the umbilicus. This is called median umbilical ligament. What we forgot to tell, that at this point, the end point of the falciform ligament is also attached. The end point, though it is not seen because it is inside. This is in a inner plane. But this falciform ligament, end of this falciform ligament is also attached at the umbilicus. Right? So, functionally, there are 5 bands, isn't it? Now, similarly, if you enter your hand in the abdomen, number one, you cannot be able to reach this upper surface of the liver beyond a point. Why? Number one, anteriorly, like this, there is a falciform ligament, and on either side, there are the superior and inferior layer of coronary ligament that is going to the right triangular ligament, like this. From the back, if you see from the back, this is groove for inferior vena cava, alright, IVC. So these two layers, superior and inferior layer of coronary ligament. This is superior layer, this is inferior layer of coronary ligament. This is right triangular ligament. This is right triangular ligament. Similarly, from the upper surface of left lobe, oh sorry, this should have been done in this side, alright. This should have been done in this side. Alright. Similarly, the upper surface of left lobe gives rise to the left triangular ligament. So, here is the falciform ligament. Here is the, oh, not this, yeah. Here is the falciform ligament. Right? So, if you enter your hand through the abdomen over the superior surface of liver, you cannot go beyond that point where the falciform ligament is at. What's my point? I will show you. I will take one class of dissection. I have added them to show this thing, right? You will not be able to access the superior surface of the liver. So this is a falciform ligament, okay? And from the porta hepatis, you see, when a girl child grows from infancy to younghood, alright, what she find? She find the girl child means, here I am talking about the uterus, alright? Here I am talking about the uterus. You know, during early childhood, the cavity within the uterus is negligible. 2.5 ml of fluid can be contained within it. Alright. But as it grows, the size of the uterus enlarges. But it still remains a pelvic organ. Still remains a pelvic organ. That is below the inlet of pelvis. Right. As it grows, she understands the dark, the filthy thing in this world. Alright, what does it feel? She feels that in front of her there is a dirty fluid bag. Dirty fluid bag, that is the bladder. And behind that there is a poo-filled bag, that is the rectum. Right? Then the girl child starts crying and prays before the mother nature. Hey mom, please let me grow. I cannot tolerate this much of shit-filled bag behind me and the dirty fluid in front of me. Alright. What then happens? Then a miracle happens. A miracle happens. There is a layer which was lying in the upper third of rectum on its anterior and lateral part. In the middle third, only the anterior surface. Alright. This peritoneum comes over the dorsal surface of the vagina. Alright. And covers whole of the dorsal surface of the vagina. That this part is quite away from the rectum. Alright. It goes to cover the posterior surface of the rectum, as well as it comes in between the bladder and the uterus. Got my point? So this is one fold, that is uterus is separated from the rectum, and that is another fold that is separating the uterus from the bladder. Right? So this is the recto-vaginal fold or the pouch of Douglas. Alright. And this is the uterovesical fold. This is the uterovesical fold. In case of male, there will be definitely no recto-vaginal fold, of course. Alright. So this fold, that is the recto-vaginal fold, is known as pouch of Douglas. Pouch of Douglas. It is at first remains very redundant. Alright. If you do a parvaginal examination and go toward the posterior folding, you will find there is a slightly boggy part behind the cervix of the uterus. Alright. It is approximately 5 cm above the external walls. Alright, you can palpate it. And whenever there is tubal rupture of pregnancy or there is pelvic abscess, alright, there will be a boggy and tender swelling in the pouch of Douglas. Got my point? Pouch of Douglas, while you do a parvaginal examination, in case of an abortion, in case of a miscarriage, abortion, tubal rupture, pelvic abscess, or any pain and swelling of the pelvis, right? So this is the recto-vaginal pouch, and then comes the uterovesical pouch. Got my point? And in case of male, there will be recto-vesical pouch, not any recto-vaginal pouch. Got my point? That's how this uterus is allowed to grow. But when this uterus gets pregnant, when this uterus becomes pregnant, she has no feeling of dirty or filthiness. She rests quite on the bag of poo, bag of shit, because there is no other way. Got my point? It will, at first, uterus is anteverted over the superior surface of the bladder. This is anteversion, right? But when it is pregnant, this gradually becomes vertical. And when the age of pregnancy increases, it leans posteriorly on the bag of shit. Got my point? This is the beauty of nature in pregnancy. Got my point? This is the beauty. At that point, she doesn't show any disgust. At that point, she cannot show any disgust. Rather, the weight of the gravid uterus is supported by whom? Behind, by the rectum, in front, by the bladder. Got my point? So these are two folds separating the uterus from the bladder. Got my point? And correspondingly, you can understand well for the male reflections also. That is, from the rectum it goes to the upper part of the prostate, that is equivalent to the vagina, posterior of vagina, covering the seminiferous tubules, alright, and then on the superior surface, and then goes to the perineum. Got my point? This is the male reflection. Now, what I was talking about the derivatives of the ventral mesogastrium, that is the falciform ligament, right and left triangular ligament, superior and inferior layer of coronary ligament, as well as the lesser omentum, from the porta hepatis. Actually, not from porta hepatis. This comes from the two margins of the ligamentum venosa. Then encloses the porta hepatis, and therefrom it falls on the lesser curvature of stomach. All right. Let me draw a diagram so that you can understand it. Now, you see, you have seen the greater omentum. That is the formation of the greater omentum. Alright. These two layers of major omentum from the liver, co-typefacies of the liver, whereas it is actually from the either side of the ligamentum venosum. This is coming below, and the two layers are encircling the co-typefacies. Co-typefacies means that is the bile duct, portal vein, that's coming out or coming in. Alright, that is called co-typefacies. On either side, there will be one thing, that is the ligamentum venosum and the IVC, and below will be ligamentum teres and fossa for the gallbladder. You will read it, don't worry. Alright, this is co-typefacies. From there, the two layers are coming to the laser curvature of stomach up to the first part of first inch of duodenum. Right? So these two layers are coming. Alright. On the above, horizontally, this is going toward this. That is towards the fundus of the stomach. And one part is going to the diaphragm as gastrophrenic ligament. Alright. Other part is going to the spleen as gastrosplenic ligament. Right. And the rest part is coming downward to form the greater omentum from the greater curvature of the stomach. Alright. What are the structures you will see in the laser omentum? You will see the portal vein, the common bile duct, alright, and the hepatic artery. Portal vein on the right side, bile duct on the left side, and hepatic artery is behind the both. Right? Portal vein right side, common bile duct left side, and hepatic artery behind, in between and behind the both. Alright, and there will be also the branches of, that is right gastric artery from the hepatic artery, alright, and the left gastric artery from the celiac trunk. You will read, don't worry, just don't worry, alright. Just listen to it and you will be able to memorize this thing. Alright, so this is the left gastric artery and the right gastric artery from the hepatic artery, that is anastomosis within this laser omentum. There is some fat, lymph node, lymphatic, all that. Okay, and from the greater omentum, from the greater curvature, you see the greater omentum where there is an anastomosis of the right gastroepiploic and the left gastroepiploic artery. Right? This is greater omentum. Right. Now, let me draw the relation of the spleen in relation to the stomach and kidney. Wherefore, you will be able to understand what are other ligaments that are forming from the dorsal mesogastrium. These are the derivatives of dorsal mesogastrium, the greater omentum, the gastrophrenic ligament, all of these from dorsal mesogastrium. Right? Let me do another to show you the lienorenal ligament. To show you the lienorenal ligament. Let me remember, one question comes. Sometimes one question comes. That is, draw the peritoneal reflection at the level of transpyloric plane. Draw the peritoneal peritoneal reflection at the level of, most commonly, at the level of transpyloric plane. That is lower border of L1. That is at the level of lower border of L1. You see. Intraembryonically, there is one outpouching of process, not outpouching, process of the peritoneum, and that is called the that is comes along with the descent of the testes, along with the descent of the testes. I have drawn one picture. This is peritoneal cavity, this is testis, it is drawn below into the inguinal canal by the gubernaculum, alright, in the first day, alright, and one pouch, one process comes along this. This is known as processus vaginalis. This is known as processus vaginalis. Only the distal part of it remains normal. That is known as the tunica vaginalis of the testis. Right? Processus vaginalis are process of the intraembryonic coelom, that is the peritoneal cavity, that comes down along the gubernaculum of testis. Gubernaculum. In case of testis, it will form the tunica vaginalis of the testis. And in case of female, this prolongation doesn't remain patent, except a small part which is known as canal of Nack. Which is known as canal of Nack, N-E-C-K, right? This is known as canal of Nack. So this is one. And another is that I have told you, that is the extra communicating with the extra embryonic coelom, right? And the fifth one giving rise to the physiological hernia which gets reduced by 10th month. Alright. Now, what you can see here, there is on these two leaflets of dorsal mesogastrium of stomach. Alright. There are two depressions. In these two layers, there are two depressions, one on the right, one on the left. Alright. The left covers, that doesn't leave it patent. On the right, this depression, alright, this depression enlarges. Right at in-pouching of peritoneum. Just like this. You see these two layers? These are the two layers of the attached to the stomach. Alright. These are the two layers of dorsal mesogastrium. Alright. One depression is here, one depression is here. This covers. Alright. But this both is in-pouching continues. This in-pouching continues behind the stomach. What my point? This is continuing behind the stomach. Alright. So this is a pouch within a pouch. This is a pouch within a pouch. This pouch is called the laser sac. This pouch is called the laser sac. Alright. And if you try to find where is the mouth from where this pouch is in-pouching, alright, that is the epiploid foramen, right there. So this outer wall is the greater sac, this space is the greater sac, and this one, what is entering into this as an in-pouching within a pouch of greater sac, that is the laser sac. That was in front there was stomach, isn't it? So this is behind the stomach. This is behind the stomach. What my point? And if you try to understand how this gastrosplenic ligament is formed, you see this is the lageromentum, this is the lageromentum. One layer from the greater sac, one layer from the laser sac. This is covering the stomach. Alright. Then it is going to embrace the spleen. Right? So this is one layer of the gastrosplenic ligament, and the other layer is contributed by the peritoneum of the laser sac. Got my point? One layer is done by one layer of the gastrosplenic ligament is done by the peritoneum of the greater sac, and another layer by the peritoneum of the laser sac. Right? Going to the hilum of the spleen, containing left gastroepiploic vessels and short gastric arteries. Left gastroepiploic vessels and the short gastric arteries. Right. Now you see, after embracing the spleen, alright, spleen develops into the left wall of the dorsal mesogastrium. Spleen develops into the left wall of the dorsal mesogastrium. And the liver develops within the ventral mesogastrium. The liver develops within the ventral mesogastrium. Right? If this is the stomach, if it is the gut, if it is the gut or the stomach, alright. So this is dorsal mesogastrium. The spleen will develop here. Spleen will develop here. That is the left wall of the dorsal mesogastrium. And liver will develop here. That is the right layer of anterior mesogastrium, ventral mesogastrium. What my point? Alright. Now you see, so the structure that develops within the wall of ventral or dorsal mesogastrium are almost completely encased by the peritoneum. As you can see, that it is a split, it is almost completely encased by the peritoneum except a small area at the hilum. Alright, and from there, this peritoneum of greater sac is coming over the anterior surface of the upper and anterior surface of the kidney. Alright, and the laser sac, posterior layer of laser sac is making another layer of this ligament. Alright, this is the lino-renal ligament. Alright, lino-renal ligament. Alright, linis means spin. From that comes the lino, tongue. Alright, and here you can see there is the tail of the pancreas as well as the splenic artery. This is tail of pancreas and the splenic artery. I am very fond of asking you a question in the examination. What makes the splenic pedicule? What makes the splenic pedicule? What structures are included in the splenic pedicule and what structure is excluded while you remove a spleen? Alright, this is I am very fond of asking this question. So you can see this, that is the gastrosplenic ligament and the lino-renal ligament. Right? And I have told about the rectovesical pouch, rectovaginal pouch, pouch of Douglas, and this layer it is appearing that it is entering behind the liver. Alright, this is entering behind the liver, isn't it? So this is in between the liver and the kidney. This is called the hepatorenal pouch of Morison. This is liver. Alright. Behind and below, a little below, there is the kidney. Alright. The peritoneum, which is coming from the ascending colon, that is entering within this space, is called the hepatorenal pouch of Morison. I will do a horizontal section of these diagrams. Alright, later on. Alright, in the dissection class. Alright. Just imagine and you will be able to understand. Alright. Now let us talk about number one, mesentery. Let us talk about mesentery, right? What is mesentery? Should I wipe it off? Actually, policeman of the abdomen. But in my view, you should not write peritoneum as a policeman. Rather, you should write peritoneum is the homemaker of abdomen. Peritoneum is the homemaker of the abdomen, right? I find this adjective to be more suitable than policeman or whatever other thing, any quality related to its martial activity, right? Now you see, what is the mesentery? Mesentery is a double fold of peritoneum, right? That connects the gut from the, that is the small intestine, from the posterior abdominal wall. Alright, this is a double fold, this is parietal layer, this is the posterior abdominal wall. From this, it is reflecting towards the small gut. Alright, this is the mesentery. What my point? As you can see, this is the vertebral border, this is the vertebral border. Alright, this border is the vertebral border. And this is the intestinal border. Vertebral border is 6 inches in length, that is 15 centimeters, right? And the intestinal border is 6 meters in length. Vertebral border is only 6 inches in length, and the intestinal border is 6 meters in length, right? Now, where from it starts? This root of the mesentery starts from the 1 point, write down 3 points, write down. Root of the mesentery starts from 1.25 centimeter below the transpyloric plane, 2.5 centimeter to the left of the midline. 1.25, that is half inch below the transpyloric plane. Transpyloric plane is lower border of L1, right? From there, 1.25 centimeter below and 2.5 centimeter from the midline, right? At the level of upper border of L2. Lower border of L1 is what? Transpyloric plane. So 1.25 centimeter will be the upper border of L2. This is the beginning of the root of the mesentery. Alright. It has two sides. One is the concave side, where from the middle column there is a posterior artery that is called the middle column entering the transverse mesocolumn. I will show you, if I get chance, I will show you each and every arterial distribution. Alright, just remember one posterior branch, which may be its first branch, that is entering into transverse mesocolon, is the middle column. Alright, or the first branch could be inferior pancreatoduodenal. The superior pancreatoduodenal is a part of the gastroduodenal artery coming from the hepatic artery. Superior gastroduodenal artery is a superior pancreatoduodenal artery is a branch of gastroduodenal artery coming from the hepatic artery. Alright, and the inferior pancreatoduodenal artery is a branch from the concave side of the superior mesenteric artery. This artery is the superior mesenteric artery. Alright, so middle colic, inferior pancreatoduodenal, then right colic, then ileocolic. This ileocolic again enters the root and anastomosis with this superior mesenteric artery. Got my point? And from this there is an antericical branch, there is an posterior branch, and there is an appendicular artery. Alright, and there is a recurrent branch from the posterior artery to the appendix. So you know the arterial supply of the appendix. Number one branch from the superior mesenteric artery directly, one branch from the posterior, recurrent branch from the posterior artery. Right? This is the branching of the superior mesentery on the concave side, not within the mesentery, beyond the mesentery. Within this fold, what we see, that is the duodenojejunal flexure. Then the duodenum, then the duodenum. Duodenum is beyond, so there will be jejunum. Alright, and after that will be the ileum up to the ileocecal junction. Alright, sometimes we can find the appendix within this mesentery. Sometimes we can find when we will do a simple operation of appendicectomy. Alright, we will see what much difficulty, how much difficulty arises in localizing an appendix. Alright, I have seen at least 5 operations where the surgeon, 2-3 surgeons were plucking their hairs, alright, and asking for help from one another. Alright, there was no way to find the appendix because in appendicectomy you cannot give an elaborated laparoscopy incision. You cannot give. Nowadays the court, the lawyer, and the defense will, and the defense, on the spot defense, will just kill you to, will beat you to death. Alright. So you will understand that if this appendix lies within this mesentery, there is no chance to find it out. What my point? So in this mesentery, you can see, first thing is that you have to understand which is the jejunal end and which is the ileal end. Alright, it is not so easy. There is a coil, right? And moving like anything. Moving like anything. And you have to find which one is the jejunal end and which one is the ileal end. In the jejunal end, the jejunal arteries are of large caliber. Number 1, these are called arterial arcades, which are 1 or 2. And these are called vasa recti. These are called vasa recti. Vasa recti you will find in kidney also. Vasa recti you will find in kidney also. Arterial supply of kidney. Right? Underline it. Write down kidney. Alright. These are the vasa recti. So, if the arterial arcades, these are called arterial arcades. Arterial arcades of jejunal artery. Of jejunal artery. Okay? So, arterial arcades of jejunal artery are 1 or 2. So, the vasa recti are long. Vasa recti are long. And as there is less amount of fat in the jejunal end, so if you take this against the light will illuminate, right? So, these are called the peritoneal windows, rectangular peritoneal windows, right? There will be presence of peritoneal windows. But in the ileal end, there are much smaller arterial arcades, much number of arterial arcades with small arcade, alright, and the vasa recti are short, and this part is laden with heavy fat. So there is practically no peritoneal window. Got my point? And these vessels are of lesser caliber than that of jejunal arteries. Got my point? If you can remember these 3 things, you will be able to find which one is the jejunal end and which one is the ileal end. Right? So this is the duodenojejunal flexure. This comes from the duodenojejunal flexure on the posterior abdominal, crossing the abdominal aorta, inferior vena cava, alright, ureter, gonadal vessels, that is for testis or ovary, alright, after crossing all these things, it comes at the ileocecal junction, where it ends at the level of sacroiliac joint. From the left side to the right sacroiliac joint. This is the root of mesentery. This is the root of mesentery. What are the structures this is crossing? Posterior abdominal wall structure. That is the abdominal aorta, IVC, gonadal vessel, right? Psoas major, quadratus lumborum, all the posterior abdominal structures, these are crossing, including the ureter near its end at the right sacroiliac joint. Done? Done? Alright. So you will be able to tell what is at least mesentery. Yes or no? Alright. So this is mesentery. Alright. Now let me tell one thing more. That is time. But very good. Alright. I will talk about transverse mesocolon, pelvic mesocolon. I will show the thing. I will take one class in the dissection room. Alright. And I will discuss the whole thing later on. I will compile everything. Alright. Remember, when you will think that I have a mature knowledge of peritoneum, I have a mature knowledge of peritoneum. When you will be able to tell the peritoneal processes, peritoneal pouches, peritoneal folds and ligaments, recesses, as well as the blood supply of any viscera, how it is entering into that viscera. Alright. When you are ready, yes, superior mesentery artery. Oh, so this is going to the root of the mesentery. It is ending near the ileocecal junction. Alright. Oh, there will be appendix. So there will be anterior cecal fold, posterior cecal fold. Right. Paraduodenal fold is this and this. There is the inferior pectoral artery, that is the superior pectoral artery, and posteriorly entering the medullary artery, going to supply the transverse fold. Right. When your idea will be complete about this fold, how these vessels are carried out to the organ, then your concept of peritoneum is mature. Alright. Up till now, your concept is immature. Alright. So you have to finalize up to that point. Alright. Thank you all for listening. Alright. Keep it.